All right, in this explainer, we're doing a deep dive specifically for you, medical microbiologist out there. We are exploring Phocaeicola vulgatus, and you should know this entire monograph is built on a comprehensive Gemini deep search, which means we're getting the absolute latest clinical picture of this really important organism. So, let's kick things off with a question that I'm sure is on a lot of your minds. You've known it, you've cultured it, you've reported it for years, but now the name on the lab report has changed. So what on earth happened to Bacteroides vulgatus? Here's our game plan. We'll start with why it was renamed, then dig into its Jekyll and Hyde personality. We'll get hands-on with lab ID, tackle the tough subject of resistance, look at how clinicians are actually treating these infections, and wrap up with prevention. Sound good? Let's jump in. So, first things first, the name change. You know, this wasn't just some committee decision. Back in 2020, powerful genomic analysis made it clear that a big reclassification was needed. It was really about correcting a long-standing misconception, all thanks to much more precise molecular data. And this is what that new family tree looks like. You can see it right there, sitting in the new genus Phocaeicola. And the reason for this big move? Well, it turns out when you look at its genes, it's actually not as closely related to Bacteroides fragilis, the big-name type species of the genus, as we all thought. Okay, so you might be thinking, a name change, so what? Well, it actually matters a ton in the real world. This forces all of us to go back and rethink decades of data. All that information from the Bacteroides fragilis group, it's all jumbled together. We might have been missing really important species-specific resistance patterns this whole time. Now, we can finally start to untangle it. All right, so we've got the name sorted. Now let's get into the really interesting part. This bacterium's personality. It's kind of like a Dr. Jekyll and Mr. Hyde situation. It can be a helpful friend in our gut, but it can also be a really nasty, opportunistic pathogen. When it's happy and at home in the gut, it's a fantastic little helper. It breaks down fibers we can't digest, churning out those beneficial short-chain fatty acids. But, and this is a big but, if that gut barrier gets broken by surgery or trauma or disease, this guy escapes. And once it's out, it becomes a major player in serious polymicrobial infections, especially those nasty intra-abdominal abscesses. And when you start looking at chronic conditions, things get even more complicated. It's not a simple good guy or bad guy story. You see, it really depends on the specific strain. Some can make IBD worse, others can be protective. It's linked to insulin resistance, but can also help with lipids. It's just a perfect example of why we have to start thinking at the strain level, not just the species level. Okay, let's switch gears and head over to the lab. How do we actually find this thing? And, more importantly, put the right name on it. So when you get it under the scope, you're looking for those classic, pale-staining, pleomorphic, gram-negative rods. Of course, it's an obligate anaerobe, so you'll see growth in about a day or two. But the real giveaway, the thing you're really looking for, is on the BBE agar. It grows just fine in all that bile, but its colonies are this distinct, pale, grayish color. That's your big clue. And this is where it gets really neat. With just 2 simple bench tests, you can reliably tell it apart from its closest lookalikes. Bacteroides fragilis and Bacteroides theta-tiodomicron, they turn the BBE agar black. Phocaeicola vulgatus doesn't. And that Indole test, it's negative, which helps separate it from Bacteroides theta-tiodomicron. It's simple, elegant, benchtop microbiology. And here's why that Indole test is so cool. It's not just for ID. It's actually a pretty powerful crystal ball for predicting susceptibility. We've known for ages that indole-negative species, like our friend Phocaeicola vulgatus, tend to be more susceptible to a lot of beta-lactams. So that negative result gives clinicians a valuable heads up while they're waiting on the full AST panel. Which, of course, brings us to the elephant in the room, resistance. This is a huge and, frankly, a growing challenge. It's a combination of what the bug is born with and the new tricks it can learn along the way. So to really get a handle on this, you gotta understand its bag of tricks. First off, it's naturally resistant to aminoglycosides. It literally can't pull the drug inside without oxygen. Almost all of them carry a chromosomal beta-lactamase, CPOF-A. Then we have the acquired stuff, the dreaded C-Fi gene for carbapenem resistance, and the incredibly common ERM-F genes for clindamycin resistance. And while it's still rare, we're keeping a close eye on NIM genes for metronidazole resistance. Okay, so here's the rubber meeting the road. The EU CAST breakpoints, version 14.0. this is what you'll use for reporting. But I want you to look very closely at clindamycin. See those parentheses? That's a huge warning sign from EUCAST. It means that breakpoint is based on population data, not on whether it actually works in patients. So even if you get a susceptible, it might not work in a real infection. You have to be super cautious. All right, we've spent a lot of time in the lab. Now let's see how all this information actually helps clinicians at the bedside, especially when they're dealing with complicated intra-abdominal infections where this bug loves to show up. Let's start with the Dutch SWAB guidelines, which are really clear and specific. For a patient coming in from the community with abdominal sepsis, their go-to is ceftriaxone plus metronidazole. For something like complicated diverticulitis, they lean towards amoxicillin clavulanic acid. And notice the durations. They emphasize short courses, especially once the source of the infection is under control. Now, if we look at the international IDSA guidelines, they take a slightly different approach. They really focus on stratifying by risk. Is it a mild community-acquired infection? Then you can use a narrower agent like ertapenem. But is it a high-risk patient or a hospital-acquired infection? Then you need to bring out the big guns, like piperacillin and tazobactam, to cover your bases. And what about kids? Well, the core principles don't really change, but as you all know, the devil is in the details. And in this case, the details are all about careful, precise, weight-based dosing. The same drugs are effective, but everything must be calculated perfectly for that child's size and organ function. Okay, last but not least, prevention. Now, this is interesting because we're not talking about your typical infection control playbook. These infections are endogenous. They come from the patient's own gut. So the goal isn't to stop it spreading person to person, it's to keep it from escaping the gut in the first place. So the best way to tackle this is with a bundled approach for preventing surgical site infections. It's really a four-part strategy. Get the right antibiotic prophylaxis in on time, prep the patient's skin correctly, maintain strict sterile technique, and, this is so important, practice good antimicrobial stewardship. Stop those prophylactic antibiotics quickly and narrow down treatment once you know what you're fighting. So, let's bring it all home. If there's one thing you take away from this, it's that the shift to Phocaeicola vulgatus is so much more than a line edit in a textbook. It fundamentally changes how we think about this organism, how we track its resistance patterns, and how we manage the very real infections it causes. Whew, okay, we covered a lot of ground there, from taxonomy all the way to treatment. Now, for all the nitty-gritty details and a full list of sources from our Gemini Deep Search, make sure you check out the accompanying notebook document. If this was helpful, do us a favor and subscribe for more explainers like this one. And please, we really want to hear from you. Share your expertise and your feedback in the comments below.